It was an ordinary Tuesday. My colleague Tomas, also an oncologist, young, bright, patients loved him. He was dazzlingly alive. Had just stopped me in the hallway to compliment me on my heels. Moments later, I heard a sound I will never forget. A heavy thud right outside my office door. I flew open the office door and I saw Tomas on the ground. I dropped to my knees and I checked for a pulse. He had no pulse. Within seconds, I began CPR. I want you to understand something. If you have never done CPR, it is one of the most violent forms of touch in medicine. It requires force, real force, often enough to break ribs. It is protocol without any attention to comfort. A code was called, my colleagues came running to help, paramedics came, and Tomas was rushed to the emergency room, where a mechanical piston took over from my hands, pressing on his chest in perfect, precise, automated rhythm. More precise than my hand or any human hand could ever be. And then he was gone. My dear friend died of an underlying cardiac issue that could not have been reversed. The room went silent. And standing over him, I could not bear that the last thing to touch him in the living world would be a machine. So I took his hand and I stayed there longer than I can remember. I want to talk to you tonight about what my hand was doing in that moment, a moment I will never forget, but one I believe medicine has been quietly forgetting over the last 200 years. Long before we have words, before trust is even an idea, it is felt in the skin. There is a class of nerve fibers called C-tactile afferents, and they live in the hairy skin of your arms, your back, and your face. And they fire most strongly in response to slow, gentle stroking, the way a mother might stroke her child. And they do not map to the seat of pressure or location. In fact, they map to the insula, the part of the brain that is the seat of emotional experience. So you have a dedicated neural pathway that, when activated, tells you, you are not alone in your body. And when that pathway gets starved, things go terribly wrong. Preterm infants in the NICU who receive structured touch gain weight faster and leave the hospital sooner. Adults holding the hand of someone they love show measurably less activation in the parts of their brain that are associated with threat. The philosopher Maurice Merleau-Ponty wrote that touch is the one sense that is always reciprocal, because of course to be touched or to touch another human is to be touched yourself. In fact, touch is the body's first language, and in medicine and society at large, I believe we have been learning to speak less and less of it over time. In 1816, in a hospital in Paris, a young physician named René Lanac wanted to listen to a woman's heart. Instead of putting his ear to her chest, he had the idea of rolling up a piece of paper into a tube, and he put one end on her chest, the other into his ear. We call this the birth of the stethoscope, and we tell it as a story of modesty. But Lanac was doing something far more consequential in that moment. He was turning the body from an object to be touched into a signal to be read. He was the first hinge in a long door swinging shut between the doctor and the healer and the patient in the bed. After Lanac came other amazing inventions: the microscope, the X-ray, the CT, the MRI, the electronic medical record. Thank you. each one seemingly a miracle, and also each one another layer of glass between the physician and the patient in the bed. Today, we have metrics for everything. We can measure how long and how well a heart beats, but we cannot measure whether a person felt held while it was beating. Now, I want to slow down here because there is another reason why we built that distance. Touch has always carried power. It is not neutral, and there is always a power dynamic between the healer and the patient in the bed. And in my profession, medicine, it has been a place where again and again and again, that power has been abused. In 1840s Alabama, a physician by the name of J. Marion Sims became famous for the gynecological surgical techniques he developed on enslaved Black women. By name, Anarcha, Lucy, Betsy, each one repeatedly with no anesthesia. Many still call him the father of modern gynecology. Their names? Barely remembered. And lest anyone think this is history, in 2018, a physician by the name of Larry Nassar was sentenced for sexually abusing over 150 young girls and women under the cover of medical examination. He weaponized the very gesture I am standing here trying to rehabilitate. He used the language of care as an instrument of harm. Every body we are in has a history. And the body's memory of betrayal does not end when that exam door closes. It is carried quietly, whether personally or medically, into every encounter that follows. So distrust of medicine is not irrational. It is often the body doing exactly what it was designed to do. I am a woman in medicine. I have also been the patient on the table. I am not asking you to forget any of this. I am asking us to reckon with it, because we cannot reclaim touch honestly until we have. But here's what we did with that reckoning. Instead of learning to touch better, more carefully, more consensually, more skillfully, we learned to touch less. We've retreated, we've documented, and boy, do we not look at screens? We have privileged sight, which feels more objective, over touch, which feels more dangerous. This retreat was not unreasonable, but we have overcorrected and mistaken distance for safety. And we have produced a generation of clinicians that we hope are fluent in cognitive empathy, the capacity to understand what a patient may be feeling, and increasingly illiterate in physical empathy, the capacity to make a patient feel safe without ever saying a word. The philosopher Martin Buber wrote that we can meet another person as an it, an object, a chart, a diagnosis. Or we can meet that person as a thou, a presence we are answerable to. Modern medicine has built an extraordinary infrastructure around the it. The thou, that person we are answerable to, has largely been left to chance. But touch can also do the opposite of harm. And sometimes it does it in one gesture. In 1987, in a hospital in London, a woman took the hand of a man dying of AIDS. She wore no gloves. Nothing about the disease AIDS changed in that moment. And yet that single act, Princess Diana, holding the hand of a stigmatized body, did more to humanize the AIDS epidemic than any public health messaging ever could. So touch can rupture trust, but it can also restore dignity. Both are true. The skill in medicine has always been to remember which one is which. So the question, as I see it, is not whether touch belongs in medicine, it's how we reclaim it. And let me be precise, because I have tried to explain why precision matters here. The touch I am talking about is the touch the patient chooses. It is asked for, it is named, and it can be refused. It is the type of touch that is offered, not imposed. That is the kind of touch I am fighting for. And here's where I want to make a claim that may surprise you. I think artificial intelligence is the best thing to happen to physical empathy in over a century. Not because I believe artificial intelligence can touch a patient, it cannot, but because every minute it takes off documentation that's painful, every diagnosis it sharpens, every annoying form it fills out for us is another minute that should be returned to the patient at the bedside. The future of medicine is not a choice between humanity and technology. It is the chance to use one to restore the other. If we get this right, really right, artificial intelligence does not replace the physician. It gives the physician the hand back. A little over a month ago, my mother died on home hospice. The morning that she died, an aide came to the house and gave her a long, beautiful shower, washed her hair, and towel dried it. My mother always loved having her hair done. And to wash another person is an ancient, sacred act of care. To a hospital billing department, it is unskilled labor. I want to know, where is the skill in medicine if it does not include this? That aide reached through the fear, reached through the frailty in my mother's body, and told her what no electronic medical record could do, what no artificial intelligence could ever do. You are still here, and you are still worthy. I was lucky enough to be holding my mother when she died. And as her mind faded and language slipped from her, her hand kept moving across my back in a continuous motion that felt like an infinity sign, like she used to do for me when I was a little girl and she would put me to bed. Again and again and again. Her body remembering a language her mind could no longer hold. We place newborns skin to skin against another body because our nervous system knows what the modern world keeps trying to forget. Our first language is not spoken, and it is not seen. It is felt. So the real question facing medicine is not longevity and whether we can extend a life, because we can and we will. It is whether in the moments that matter most, do we know how to remain human inside of them? Will we reach through the fear, the efficiency, and that glass and remind one another, you are still here. You are not alone, and you still matter. Thank you.